In this video, we'll discuss about resistant hypertension. So the blood pressure that remains above the goal in spite of concurrent use of 3 antihypertensive agents of different class is known as resistant hypertension. Patients whose blood pressure is controlled with 4 or more medications are also considered to have resistant hypertension, and if tolerated, one of the 3 drugs which are being used should be a diuretic. All agents should be prescribed at the maximum recommended dose before classifying patient as having resistant hypertension. So before diagnosing resistant hypertension, we should always rule out pseudo-resistant hypertension. The pseudo-resistant hypertension is a poorly controlled hypertension that appears resistant to treatment but is actually attributed to other factors like inaccurate measurement of blood pressure, poor adherence to antihypertensive therapy, suboptimal therapy, as well as poor adherence to lifestyle and dietary modification, and in some cases white coat hypertension. The risk factors and the causes responsible for the resistant hypertension include the patient characteristics like higher baseline blood pressure, presence of left ventricular hypertrophy, older age, presence of obesity, and the CKD and the diabetes. Similarly, there are some reversible factors which are responsible for the resistant hypertension. If we can treat these reversible factors, then the blood pressure can be reduced. These reversible factors include suboptimal therapy, lack of proper lifestyle in the dietary modification, use of the medicines which increase the blood pressure, like use of NSAIDs and the herbal preparations, and other secondary causes of hypertension like primary aldosteronism, renal artery stenosis, CKD, and the obstructive sleep apnea. This is a chart which is taken from the ESC guideline of 2018 for the management of arterial hypertension, and this guideline basically summarizes the characteristic of the patient with resistant hypertension and also outlines the major causes of resistant hypertension. So the patients usually are of older age, obese, mostly black people with excessive dietary sodium intake and with high baseline blood pressure, and these people also have concomitant diseases like CKD, left ventricular hypertrophy, diabetes, and other atherosclerotic vascular disease. And the major causes for the resistant hypertension include primary hyperaldosteronism, atherosclerotic renal vascular disease, sleep apnea, CKD, and the uncommon causes include pheochromocytoma, fibromuscular dysplasia, aortic coarctation, Cushing's disease, and hyperparathyroidism. And similarly, we should also consider the prescribed drugs as the cause of resistant hypertension. Drugs like OCPs, NSAIDs, erythropoietin, steroids, they can cause resistant hypertension, and in some high-risk populations, we'll need to consider the use of recreational drugs like cocaine, amphetamine, and the anabolic steroids as the cause of resistant hypertension. So now moving to the diagnosis. For the diagnosis, first of all, we should measure the blood pressure accurately. Clinic or hospital measurements can produce errors due to the presence of white coat hypertension, so ambulatory or home blood pressure monitoring is preferred. Similarly, we should look serum electrolytes to rule out hyperaldosteronism. We should also look for the urinary albumin to creatinine ratio. We should also screen the patients for primary aldosteronism. We should evaluate the 24-hour urine for sodium excretion, creatinine clearance, and aldosterone excretion. Similarly, patients should be evaluated for pheochromocytoma, and we should also perform non-invasive imaging for the renal artery stenosis. For the treatment, we have to understand the general principles, which is we need to first identify and treat the secondary hypertension, and we should stop the medications and that raise the blood pressure, and if necessary we should refer patient to the hypertension specialist in a timely manner, and we should monitor the blood pressure regularly. So the major treatment modalities include non-pharmacologic therapies, pharmacologic therapies, and renal nerve denervation. In the non-pharmacological therapies, reducing the salt intake is very important. Similarly, obese patients or overweight patients should be advised for weight loss, and we should ask patients to reduce their alcohol intake. And in the pharmacological therapy, first of all we have to consider the presence of any reversible secondary cause, and we should treat them. If the blood pressure persists on the higher side even after treating these reversible causes, we can use the combination of 3 or more drugs including a diuretic, and the long-acting combinations are preferred because it will increase the adherence and compliance of the patient. While considering the use of the diuretics, if the patient has a little renal impairment, we can start them on the chlorthalidone, indapamide, or hydrochlorothiazide. And if the patients have GFR of less than 30 ml per minute, then we can start them on the loop diuretics like furosemide and torsemide. Similarly, in selected group of the patient, we can use mineralocorticoid receptor antagonists like spironolactone and eplerenone. Next modality of the treatment is renal nerve denervation. It can be achieved by catheter-based radiofrequency ablation or catheter-based ultrasound ablation. However, this is not used frequently, and its effectiveness is yet to be established. And now the choice of the regimen basically consists of use of the ACE inhibitor or the ARVs in combination with long-acting dihydropyridine calcium channel blockers like amlodipine, with long-acting thiazide diuretics like chlorthalidone and indapamide. However, if the fourth drug needs to be added, then spironolactone is the preferred drug, and if fifth drug is needed, we can add vasodilating beta blockers like labetalol, carvedilol, bisoprolol, or nebivolol. Also, we can use centrally acting agents like clonidine and guanfacine. We can also use direct vasodilators like hydralazine and minoxidil. And there are some experimental therapies like electrical stimulation of the carotid sinus baroreceptors and creation of a central arteriovenous anastomosis. However, these are experimental therapies and are rarely practiced in the day-to-day basis. So now talking about the prognosis, these patients with resistant hypertension are more likely to present with the target organ damage, and they are at the greater risk of stroke, myocardial infarction, heart failure, and chronic kidney disease. So we need to identify this subgroup of patient, and we have to treat them aggressively to reduce these complications of the resistant hypertension. So these are the reference of today's lecture. If you want to learn more about the resistant hypertension, you can go through them. I hope this video was useful. Thank you.